all. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So, the discussion today is about a study which demonstrates the incidence of myocarditis, pericarditis in children and young adults from age 12 to age 39. However, in this study, the highest incidence of myocarditis, pericarditis after the mRNA vaccines in the US was between 12 to 17 years of age. So the links to the study are in the description. You can please, my request, you can go over the study itself as well, so that if I have made any errors, you can see them and correct them. At the same time, I'm only going to focus on 12 to 17 years of age, and you may be interested in other ages as well, so please look at the study. Let's start our discussion. So quick references. First of all, there is a link in the description of this video. This is that link. Do you know that that link gets you access to Dr. Bean plans, one-time fee, one time, never again, for $67. I do not think you can get 900 videos, medical content, premium content at this price. So with this, here is the study. It's printed in Annals of Internal Medicine, and the study title is Incidence of Myocarditis, Pericarditis Following mRNA COVID-19 Vaccination Among Children and Young Adults in the United States. It is a letter, and it is printed on 4 October 2022. Let's look at the basic idea in this one. What is interesting when you go through this table, and it is actually the PDF is behind a paywall, so you'll have to kind of increase the size of this PDF and look at that blurry data and see it. And I have gone through some of that data, and I would present it. What we'll do today is the following. Number one, we'll look at this data. Number two, I wanted to figure out that in case of SARS-CoV-2 infection and the MIS-C outcomes, or multi-system inflammatory syndrome of COVID, that happens in children, actually it happens in adults as well. What is the incidence of cardiac issues in that situation? So I have both of these data points. Some of the data are actually projections or extrapolations. So of course, if these are extrapolations, these could be wrong as well. And it depends which study I took and extrapolated. There are always studies of all kinds. Then specifically in case of children, the data is all over the place. The percentages are all over the place. For example, for the MIS-C, there is data that says very few children that develop MIS-C after COVID infection, very few of them have comorbidities. Then I would show you studies that say about 50% have comorbidities. There is also a study that says about 75% have comorbidities. So data is all over the place. And my work here today is going to be, intent is that if you have a child, then you should be able to at least have enough links with you to see if the infection occurs, what is the possible outcome. If the vaccine is used, what is the outcome, the comorbidities, the age, the race, the ethnicity, all of that is something that are in these links. You can have that information for yourself. That is the intent. Let's look at the data. So these are gifts for humanity. They are continuing. This is now from the main study. What they said was, they looked at the patients of myocarditis, pericarditis after the vaccination. And what they looked at was from December 2020, 5 year to 39 years. I said 12 to 39, 5 years to 39 years. 18 to 39 years of age, that was 30 May, December 2020 to 31st May 2022. 5 years to 17 years, the data was from December 2020 to 20 August 2022. This is the data set or the durations. In this time frame, there were 320 cases of myocarditis, pericarditis. Myocarditis means the inflammation of the heart tissue, muscle. Pericarditis means inflammation of the layer that covers the heart muscle or heart itself. There was when I did the discussion yesterday, there were lots of comments that myocarditis is never repairable. And that's actually incorrect. Itis means inflammation. Many times inflammation can have full recovery. It depends upon the intensity of the inflammation. If inflammation becomes too much, then myocardial infarction would occur. When the myocardial infarction or the tissue death occurs, then that is not reversible. Now, it is also possible that with myocardial or myocarditis, there may be severe enough inflammation that it doesn't cause the tissue damage, so there is no infarction, but still there is scarring, and there may be still calcification present in the heart. So this concept that myocarditis is an irreversible cardiac damage is not a correct concept. It depends upon the amount of injury, amount of inflammation. So 320 cases, 6.9 million about vaccine doses. These cases occurred anywhere from 1 day to 98 days after the vaccine doses. Out of these 320 cases, 224 were verified cases. That is 70%. That means child got the vaccine. Well, in this case, there are children and young adults. I missed this this age now. Up to 39, I could have been called young adult. I wish I'm called young adult now as well. So anyway, 70% of them, of all the cases, were verified to be cardiac issues. Out of these 70%, 137 cases were within 0 to 7 days of the vaccination. So 61% of the cases occurred within a week after the vaccination. 18 occurred after the first dose, and there were 3.5 million doses. 119 occurred after the second dose, and there were 3.4 million doses. So I would put the summary once again in front of you, and that is highest incidence of myocarditis and pericarditis after the vaccine occurred after second dose in males between 12 years of age to 17 years of age, mostly in Hispanics and blacks or other than white ethnicities. That is the basic summary. So now here, and also in men. So incidence was higher in men after second dose. Now here is the important data points. And these are from the table. I'm going to show it to you for the table as well. For the age 12 to 15, there were 31 cases out of 205,955 doses. That is about one case, actually not about, actually one case out of 6,643.71 doses. That was 12 to 15 years of age. 1 out of 6.6 thousand. 16 to 17 years of age, 2 years, 14 cases, In this study, 14 cases out of 102,091 doses. So that is one case after 7,292 doses. About 6 to 7,000 doses. Let's say one dose is for one unique person, one unique child. So out of 6,600 children, one will develop myocarditis in the 12 to 15 years range. In 16 to 17 years range, when 7,292 children get the dose, one will develop myocarditis. And if I go here for a second, and I'm going to do the same thing, trying to make it bigger for us to look at. So look at this. This table on the left is the vaccine type and the age. Then the first two columns after the left column, dose 1, then dose 2, then final booster. And what they have done is cases per dose and incidence per million. I have done another calculation. For example, if you look at 12 to 15 years, 31 cases out of 205,955 doses administered, and I did what will it take for one case, and that is what I just presented. Interestingly, even 5 to 11 years of age do have cases, and other ages have them as well. After the first dose, the incidence is lesser. Second dose and booster incidence is more. And once again, males have more. So this is the incidence. Out of 6,600 doses in 12 to 15 years of age, one child would develop myocarditis or pericarditis. Out of 7,292 for children, male especially, 16 to 17 years of age, one of them will develop myocarditis, pericarditis. Then the second question became, for me, that how does it compare to SARS-CoV-2? And that is where there is just so much slush of information that I can say confidently that any study set that we pick up will be countered by another study set. So here what I would present is the links, the studies that I have used, and those are linked here. I have not used any blogs posts or any such studies. These are all regular journals and the studies in there. So let's look at them before I show you the data. So now we are switching from vaccine caused or associated myocarditis, pericarditis to SARS-CoV-2 related. And this is not going to be an apples to apples, one-to-one comparison. So there are going to be some differences. So first thing to realize, this is University of Florida. About 35% of all COVID-19 cases never show symptoms. And if you see here, and this is the date is August 23, 2021. If you go down here, it says, the study authors found that of the truly asymptomatic cases they analyzed, nearly 47% were children and 20% were elderly. So here, please hold on to this thought, 47% children are asymptomatic. Actually, you may have heard that nowadays that number after Omicron is even different. But let's look at the data that we have. This is University of Florida, about 50%, let's say. Then here is another study. This study is, if you see here, Vaccinology and Immunology Research Trials Unit, Women's and Children's Health Network, Adelaide, South Australia, Australia. So this is a study, I think this is a preprint from Australia. And here they are saying, if you look at this part, asymptomatic throughout infection was 44.1%. So the overall estimate of the proportion of people who became infected with SARS-CoV-2 and remained asymptomatic were about 44.1%. So this is another number. This number is all individuals, not children. The previous number that you saw was 47% for children. But now the dates are different. Date difference means the variant is different. So you have to, if you have a child, you have to do all those um, researches to figure out what does Omicron cause as asymptomatic cases, and then what does infection cause, then what is the comorbidities of the child, then what is the kind of risk to heart that child would have. I'll continue to present the same data here as well. So two studies. Then this is SARS-CoV-2 infection and associated cardiovascular manifestations and complications in children and young adults, a scientific statement from the American Heart Association. This is AHA, American Heart Association. And the date is 11 April 2022, so pretty recent. That means they have access to more recent data. If you look at, this is quite a comprehensive study, decently written, I like it. So if you see some of the data here that is interesting is the following. In the first year of the pandemic, so first year, we are now in the Omicron era, they're talking first year. In the first year of the pandemic, more than 2,600 cases of MIS-C were reported. So we're not talking about infection anymore, we're talking about the severe outcome. Although remember, severe COVID versus MIS-C are two separate branches. They both have severity, but they are kind of separate. In the MIS-C, there is inflammation of the heart involved as well. So, and not all cases, I'll explain that. So MIS-C were reported to the Center for Disease Control. I hope my audio is working. I always get scared if the audio is working or not. If it came from the University of Florida, my alma mater, it has to be true. So John is saying that that means my audio is working. Okay. So back here, sorry for the quick interruption. So MIS-C were reported to the CDC, and prevention on estimated rate of one case of MIS-C per 3,164 cases. So one case of MIS-C out of 3,164 infections. Keep this in mind, please, because there is another important data point that is coming, and I have written them down here as well. But let's do some of this together. Then down here, they say in pathophysiology, what are the various kinds? And I have discussed these in the past. Some folks have criticized me that I don't talk about the disease itself. I think I have talked about this disease the most. So all of these mechanisms that are here, I have covered 1.5 years ago. Okay, now next. Here is another study. This study, so let me back up for a second. Now we know that one case of MIS-C occurs out of 3,100 cases of infection or infections in children and young adults. This is another study that says it is April 6, 2021, trends in geographic and temporal distribution of US children. This does not include young adults, US children with multisystem inflammatory syndrome or MIS-C during the COVID-19 pandemic. There is an important data point in here. Research. I had to do the whole day today. So let's see. This is an interesting data point. Cardiac dysfunction was reported. So again, they use the term cardiac dysfunction. They didn't say cardiac myocarditis or pericarditis or myocardial infarction or angina or any other cardiac issues. This is why I said these are not apples to apples or one-to-one comparisons. Over there, the study is talking about myocarditis, pericarditis. Over here in MIS-C, we're talking about cardiac dysfunction. This is important that cardiac dysfunction was reported in 31% of the patients of MIS-C, which means if there is one case out of 3,100 infections, then 1/3 of that case may be cardiac. So of course, we cannot have 1% and 1/3. So that will mean we'll have to have about 9,300 patients of MIS-C to have one patient with cardiac outcome. Right? So the data is here. 31%. Then, if I continue, this is another study. This is published 10 September 2020. Springer. COVID-19 severe acute respiratory syndrome, infection in children and adolescent is systemic review. And here what they're talking about is the patients who become critical and severe. Remember I was talking about MISC. Here is the severe cases. And what they're saying is, so they say in this study, 108 children were ventilated. The medical history was available for 48 patients. 36 of the 48 patients, or 75%, had documented comorbidities, of which 11 or 23% had pre-existing cardiac diseases. So in severe cases when the heart may be involved as well, overall here 75% had comorbidities. That also means that 25% were healthy and became severe. Then here is another data point. All of these links are in the description. This is up to date. And in the up to date epidemiology they talk about, the MISC, they say, while the incidence of MISC is uncertain, it appears to be relatively rare complication of COVID-19 in children, occurring in less than 1% of children with confirmed SARS-CoV-2 infection. So mind it, they're saying confirmed SARS-CoV-2 infection. So there is still a uncertain area, and that is asymptomatic. So these numbers are out of the confirmed cases. Remember, asymptomatic is about 50%. So that means if, for example, we have, this is now warning, heads up, this is me, and you might say that you don't agree with this way of thinking. My thought is that if we say one case out of 3,100, these are 3,100 confirmed cases. These 3,100 mean that there are another 3,100 who were asymptomatic. So that was actually 6,200. 3,100 were asymptomatic. The other 3,100 had the proven positive infection. Out of them, one became MISC. Out of that one, actually 1/3 would have the cardiac outcome. So basically, we should take 6,000 multiplied with 3, 18,000. Out of 18,000, one child would have cardiac issue after MISC. So here, I'll go to the numbers. I've written them down. So occurring in less than 1% of children with confirmed SARS-CoV-2 infection. In one report from New York State, the estimated incidence of lab-confirmed SARS-CoV-2 infection in individuals lesser than 21 years old was 322 per 100,000, and the incidence of MISC was 2 per 100,000. So that is this data. You can see that how diverse the data is. So here, incidence is 2 per 100,000. We just saw in the AHA 1 per 3,100 infections. Then the epidemiology of MISC also differs from the severe acute illness, and I showed you that data separately in children, which more often occurs in children with underlying health problems. MISC, they say, is possibly children with complete or incomplete Kawasaki disease. Once again, the data is all over the place. We just saw AHA journal extrapolating it in other ways and showing pathologies. So if I go back here, where was that? Believe here. So here, their pathologies are very different. And when UpToDate is talking about it, they are saying Kawasaki is primarily the complete or incomplete, maybe a main driving factor. Then here is another study. This is cdph.ca.gov, so Canada. Oh, sorry, California, Canada. So MIS-C comorbidities, California. About half of children and teens who had MIS-C had no known previous health conditions or comorbidities, 53%. The other half, so remember, we just saw 75% with the acute, here 53%. with the MISC. The other half of children with MISC had a known or reported existing medical condition, the most common being reported as other and obesity. Then here is another. This is Mayo Clinic, and they're talking about how likely is it for a child to become sick with coronavirus. Children represent about 19% of overall COVID cases. While children are as likely to get COVID as adults, kids are less likely to become severely ill. Up to 50% of children and adolescents might have COVID-19 with no symptoms. So that is once again asymptomatic cases. Then a couple of more things here, out of which this one study is very interesting. This is kind of a little bonus study in here. Very interesting. In this study, they said that those adults that live with children develop COVID more frequently, but develop severe COVID less frequently. And the reason they're saying is that possibly children have cross immunity because of other respiratory diseases that keep developing and they are exposed all the time. So because children have developed immunity, because of that, if the adult that lives with them, also these adults have also developed immunity because child gives them infection and other respiratory infections, which causes the immune system to become trained, and I've discussed that in the past. But it is interesting for me. Let me read it. This was very cute for me to see. They're saying, however, adults without exposure to children had lower rates of COVID-19 infection, but significantly higher rates of COVID-19 hospitalization. So that's interesting. Anyways, so now let's go back to this data point. Here, what we have to see is this 75%. Let me start from the beginning in this part. 47% of the children are asymptomatic. 1 out of 3,164 is MISC. Within MISC, cardiac issues are 31%. Now, children who become severe, 75%, who have MISC, about 50%. So that means this number over here, we can use either of the numbers, 75% or 50%, because they both actually go towards the severity. Although in the case of 75%, this is MISC, which has a component of cardiac outcomes. So now if we talk about one child developing cardiac outcome, that will mean from SARS-CoV-2, that will mean there have to be 3 MISC patients, out of which one will develop this. Even more than 3, right? Because 31% have cardiac issues. Which will mean that if we take 1 out of 3,164, I actually took it on the lower side, about 9,000 cases of infection will give rise to 3 MISC, out of which one will have cardiac outcome. And now if these are the 9,000, then, and the asymptomatic cases are 50%, then that means there are another 9,000 who were asymptomatic. So a total of 18,000 infections occurred. 50% stayed asymptomatic, so we didn't hear more about them. 50% became proven COVID. 9,000 of them were here. 3 of them developed MIS-C, and then one developed cardiac outcome. So this 18,000 is my extrapolation. And I went back from here. So that means I could be totally wrong. Or you could pick up another set of studies, and this number may be all different. These numbers are all over the place. But for me, what is interesting is, if we use this set of studies, one patient of cardiac outcomes out of 18,000 infections, compared to one case of cardiac outcomes out of 6,643 vaccinations, or one case of cardiac outcome in 16 to 17 years of age out of 7,292. Now, my math can become wrong in 2 places. If AHA journal said one case of MISC per 3,164 cases, and these 3,164 cases included asymptomatic. And if they did, then half of them will be asymptomatic. Then this number will, instead of being 9,000, it will become 4,500. So that is one area. Second area, and of course, this number could be a little bit higher because it is 31% and not exact 33 point some percent. Second, this number, comorbidities, you have to look at it from 2 point of views: Miss C or acute infection or severe acute infection. Severe infection comorbidities, about 56% become severe or have cardiac outcomes. In the Miss C, 75% have comorbidities. So that is another data point that varies. And finally, how many get Miss C? As you saw, 2 cases out of 100,000 or 1 case out of 3164. That is a very wide range as well. So based on those ranges, these numbers can be so different from each other. Now, this is the end of the discussion, but I wanted to share the limitations of this paper as well so that we are clear. They said important limitations include the lack of a control group. So this particular study that is showing myocarditis, pericarditis after the vaccination, they said we did not have a control group. And because they didn't have control group, they percolating causal inference. They said we cannot infer that is it the vaccine that caused it or not. Second, cases were also identified only in emergency or inpatient. This is a very important point. They are only counting the cases that were in the emergency department or inpatient hospital. They were not counting cases if they may have occurred at home and child never actually went out to be counted, had a, let's say, discomfort or pain, but got ignored and became okay or not okay, but never appeared in the hospital. Or the child that was managed in outpatient, so went to the doctor said, all right, let's do this, do not know the doctor reported it or not. So that is also not included here. So they are admitting that that is a limitation. So it is possible that actual data may have been more. Thus, cases were not identified if they were seen only in outpatient settings or if they received less specific diagnostic codes such as chest pain. So this is another, that if patient actually did arrive in inpatient, but instead of giving them cardiac disease code, they were given chest pain code. Now, chest pain can be because of, let's say, upset stomach or esophagus or other reasons, pulmonary reasons. So there are many other possibilities of chest pain. Further limitations included excuse me, potential reporting and ascertainment bias, potential differences between individuals who received Moderna versus Pfizer, and underreporting of SARS-CoV-2 infection. So these are the data points. Please do me a favor, like, subscribe, and share. If you have a child and you would like to look at what are their chances, all the links are in the description. My request will be to start from this studies table to first of all see male, female ethnicity, then see what is the cases for doses, divide them to see 1 case out of how many, then look at your child's comorbidities, and then based on that you can see the rest of the data as well to see the risk and then make a decision with you and your doctor and your family. So please like, subscribe, and share. I also wanted to discuss one more thing, and that is in a couple of weeks there is FLCCC conference in which I am presenting as well. I always put myself in trouble by doing artistic work. So I have been slowly building that presentation. However, I have to yet talk about autophagy spermidine, resveratrol, coffee, lytic breakdown of the uh, proteins, that is autophagy, and the ubiquitin based breakdown. So there are tons of diagrams to be made. So I did the whole last week and did not make more than one third. So I'm going to take this week off to work on those, on that presentation and finish it. So I would not be resting and relaxing, but instead I'll be finalizing the FLCCC's presentation. I think if you are going to be in the conference, you would enjoy. There's a lot and lot of diagrams in there. In the meantime, once again, um, please do me a favor. In the description of this video, there is a link to this YouTube. This is the link. This is a link for premium access to drbeen.com content. It's only for $67. And that is not a recurring payment. That is not a limited 1 month payment. It is actually for as long as Dr. Bean is there and I am there. And the $67 is one-time payment, no recurrence. And even then you can return it if you like. And this gives you access to another. It says 800 here. This is an older page. Now we are at 967 videos. And I have just started a complete new course for microbiology. And you will be so happy with the diagrams in there. That microbiology is not here on YouTube. So this is the discussion. Truth Seeker says, does Dr. Bean ever really relax? I have not. For at least last 2.5 years, I have never taken this many days together. But I wish these were for me to go have fun somewhere. I actually need to finish FLCCC's work so I don't end up with half-baked presentation. So do me a favor. In the meantime, please like, subscribe, and share. Please see if you would like to have support for this work. There are links in the description for Dr. Bean, for PayPal, buying me a coffee, Substack, YouTube membership, and so on. Thank you, Paul. Patrick, thank you very much. Parth, Parth says start biochemistry. Parth, I've started immunology because I'm writing that book as well, plus started microbiology. And let me just give a quick look at how beautiful the microbiology work is. So if I go to drbeen.com, if you go to video library, these are the two that have been released. And I have already done 15 videos on microbiology. And if you look at how beautiful this work is, just look at these diagrams. This is a beautiful work with a lot of love and care. And that all is actually within the $67. It's crazy that we have such a low price with all of this. All right. So with this, I'll see each other. We'll see each other on Monday. If there is some really, really important news, I'll come back and discuss. Otherwise, see you on Monday. Have fun, enjoy, take some break, watch some of the videos from the previous times, and there are links in the description to support this work. Thank you very much. See you on Monday. Bye bye.